Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and independently sponsored by Amgen.
This program is presented by Medscape Education Global.
Hello, I'm Guy Ben Simon, an ophthalmologist based in Tel Aviv, Israel. Welcome to this activity, Fresh Perspective in Thyroid Eye Disease. It's my pleasure to be joined today by two friends and colleagues, Mario Salvi, an endocrinologist with a special interest in thyroid eye disease based in Milan, Italy, and Piruz Said, an orbital surgeon based in Amsterdam, the Netherlands. Those of you watching this may be endocrinologist, ophthalmologist, or oculoplastic surgeon. You may not be directly involved in treatment and decision-making in thyroid eye disease. Mario, can you please start by explaining why it's important that people watch this and also give us some background on where we are at in thyroid eye disease?
Hi, everyone. Thyroid eye disease associates to Graves' disease, which is actually characterized by autoimmune hyperthyroidism due to the stimulation of the thyroid by autoantibodies to the TSH receptor. For that reason, the disease associates in most cases to Graves' hyperthyroidism, about 90% of patients, but it may associate also to Hashimoto's patients, and in some cases 4 or 5% in a situation with euthyroidism, no apparent involvement of the eye disease. The disease, though, occurs in not in all patients with Graves' hyperthyroidism, and this is still unknown. In average, about 50% of patients may have this disease associated. The physiopathology of the disease derives from the fact that thyroid eye disease is an inflammation of the orbital tissue, especially the eye muscles and the retroorbital tissue. And that causes a protrusion of the eyeball outside of the orbit, which is characterized as the exophthalmos or forward proptosis of the eyes. The management of hyperthyroidism is very important because for the correct management of thyroid eye disease, it is important to keep the patient euthyroid as early as possible. And the various modalities of treatment of the thyroid disease are really related to the fact of the stage of the eye disease at the onset. Because if we have mild disease or inactive disease, we can use any kind of treatment for the thyroid disease, from antithyroid drugs, thyroidectomy, or even ablation with radioiodine. But in the case of the disease, when the disease is in the active phase or when the disease is severe, the priority goes to treatment of the eye disease while the patient is being kept euthyroid and antithyroid drug. What we know about the treatment with the antithyroid drug, if the disease at onset has very mild manifestation of the disease, we can keep the patient euthyroid, and very rarely this disease progresses. The difference is when the disease at onset is more than mild. I mentioned before that the TSH receptor antibodies are stimulating the TSH receptor to produce hyperthyroidism. And there is a clinical relationship is being shown between these circulating antibodies and thyroid eye disease. We have seen that the more severe forms of thyroid eye disease usually associates it to more elevated titers of this TSH receptor antibody. And certainly the treatment that we apply to the underlying thyroid disorder has an impact on the titers of these antibodies. This is why, in case of active thyroid disease, and conservative treatment with antithyroid drug is preferred, for example, to radioactive iodine, which may elicit worsening of the disease. The clinical course of TED is characterized by a biphasic curve. Actually, was described by Randall in the about 100 years ago. And this is characterized by an active progressive phase where inflammatory signs prevail, followed by a stable phase and even somehow some sort of improvement of the disease itself. So the disease is in most cases self-limited, and this has to be kept into consideration for approaching the management of the disease itself.
Thank you, Mario, for this beautiful introduction. Piruz, when we have a patient in front of us in whom we suspect thyroid eye disease, how do we make that diagnosis or that referral? And how should we assess the disease activity in that person?
Thank you, Guy. I will give a short introduction on assessment of thyroid eye disease. Before starting with eyes, I will say that for assessing the thyroid eye disease patient, it's also important to address a couple of other signs in their body. One is peritibial myxedema, and the other one is the nails, the clubbing nails, and peritibial myxedema. They can be associated with some severity, but less prognosis of disease in those kind of patients. So the most common sign of thyroid eye disease is probably proptosis combined with lid retraction. They can be present together or can be only lid retraction of either upper eyelid or lower lid. And actually upper eyelid retraction is more common than lower one. The lid retraction should be differentiated from elevation restriction, which is also very common in thyroid eye disease patients, and that is also for correction of this kind of problems. You should your approach should be different. As I mentioned, the limitation in upgaze is maybe the most common sign of squint in the thyroid eye disease patients. That is due to the fact that inferior rectus is the most involved muscle, and since it's restrictive eye movement, then they are not able to look up. To evaluate and to assess the eye movement problem and double vision, we do orthoptic evaluation, and our orthoptists they have their own tools to evaluate this, and this is very important to evaluate the progression of disease or being able to say the patient is stable. Many years ago, there was an attempt to classify the disease, because there is a difference in presentation. Werner in '60s started to try to standardize the evaluation and assessment of thyroid eye disease patients with no specs. This is just looking at the sign and symptoms that we see, and that was a very easy way of description. However, that did not describe the course of disease. So later, in '80s, this no specs was used also to classify the severity of disease. The patients were either mild, and that was when there was no significant impact in their daily life. There was a little bit of lid retraction or a little bit of proptosis, but for example, no diplopia. While moderate to severe was associated with muscle involvement, extraocular muscle involvement, and that was diplopia, but also more proptosis and probably more lid retraction. And the most threatening aspect of presentation of thyroid eye disease is sight threatening or this thyroid optic neuropathy. In these patients, very often there is not much of proptosis, but muscle is so large that has caused mechanical pressure in optic nerve. I mentioned that no specs was not addressing the course of the disease. In end of 80s, Maurice and Versinghoff, actually from our own center, they try to also evaluate the course of disease to see which patient has a progressive disease and which one is stable and which one is improving. So they just classified based on inflammation signs, and that was the later was had additional items, and that was increased proptosis and motility worsening. So the patients were classified in the upper. In this picture, you can see a patient with swelling of eyelids and caruncle swelling, that is the inner part of the conjunctiva. And the second, this patient has just a slight swelling of the eyelids. These patients, they have more severe activity. They have significant chemosis, which is the swelling of the conjunctiva, redness of the eyelids, and redness of the eye. And when it's combined with a pain, then you are talking a very active thyroid eye disease patient. When these symptoms are long-standing, make it difficult to differentiate between the congestion and real activity and inflammation. To evaluate patients, also imaging is very important. In this CT scan, you see that there is significant proptosis, but only due to increased volume of fat, while the other CT scan shows the enlarged muscles, apical crowding, which means that there is not much space left for the optic nerve, and a candidate for dysthyroid optic neuropathy. Later, we also started to evaluate patients not with only CT scan, but with MR, because we believed, or the studies has shown, that on MR you can also more objectively being able to assess whether there is activity, because there is sometimes in those muscles, on those coronal images, you can see that there is edema in the muscle, which is probably a sign of activity. So to make a diagnosis of patients with thyroid eye disease sometimes can be challenging. When you have increased level of antibodies, TSA receptor antibodies, and you have typical signs of thyroid eye disease like lid retraction, proptosis, restrictive diplopia, and typical aspect on the imaging, then you have made a diagnosis of thyroid eye disease. But it's not always this clear cut. You have patients that they have, for example, clinical aspect of thyroid eye disease, but no antibodies. In those kind of patients, you should decide very often in combined clinics to come to a conclusion and having a practical the diagnosis and the workflow for this kind of patients. Thank you.
Thank you, Peruz, for this excellent presentation, and I totally agree. Sometimes the diagnosis can be challenging. So, considering the different specialists involved, what's the best workflow for ophthalmologists and endocrinologists to work together to diagnose and manage patients with thyroid eye disease? As we have seen in the previous presentation, there are several problems. Some patients have very mild disease, some have sight-threatening disease like dysthyroid optic neuropathy, exposure keratopathy, or globus luxation. So when you see a patient like that, what would be the best workflow for you to choose? So Saudi, we'll start with you.
Well, I mean, as I mentioned before, I think it's fundamental that the ophthalmologist and the endocrinologist work together. The first step is really to get as quickly as possible control of thyroid function. And especially, as you mentioned now, in the more severe cases, I think that it is not important to decide for a definitive treatment of thyroid disease, but just to get control rapidly with antithyroid drugs, which are really very easy to handle and they're very well tolerated. and this is actually something that with a skillful endocrinologist can be obtained within 4 to 8 weeks maximum from onset of the disease. And then certainly it depends on the, as Pirou said before, on the activity of the disease, the degree of disease, of severity of disease, and there is certain necessary interaction to decide for immunotherapy or immunosuppressive therapy if that's needed.
And what's your thoughts about antibody negative thyroid eye disease or presumed TED, which you are almost 100% positive that the patient has thyroid eye disease, but no autoantibodies?
Well, there's no, I mean, the fact that we do not measure antibody doesn't mean that there are no antibodies. In fact, it depends on the technique we use. There's certainly limitation in some of the techniques we used. We've done in the past studies in which we, for example, performed some immunoblotting of the serum patients with thyroid eye disease, and all of them had some antibodies. The point is that they're not easily recognizable. Autoimmune disease is a polyclonal disease by definition, so there are several antibodies. The ones that are well known are the ones that we usually measure, but there are certainly other antibodies that we do not know the antigen they react to.
And Peruz, when you see a new TED patient, do you first send him to endocrinologist? Do you work in a multidisciplinary clinic, or you treat them yourself?
No, we have traditionally we have a multidisciplinary clinic. We have a Graves clinic, which is they are run with ophthalmologists specialized in orbital and oculoplastic surgery and with endocrinologists. Actually, this was in our clinic was started in I think in 70s, and we have a tradition to working that way, and we have seen the advantages. Because like what Mario just mentioned, that you have a patient with a complex, also in diagnosis, complex aspect. And then when you are together, you can in decision making also, and also interaction with patient is much better. When you are together and explaining the whole this thing to the patient, also for patient is very important. That has both specialists together and they are explaining something on their disease and also course of disease. And for sure, the patient with moderate severe or the thyroid neuropathy, this is very important that ophthalmologists and endocrinologists are working together to make a plan, treatment plan. I am also aware of the fact that this kind of combined clinics are not always everywhere possible, depending on the structure of the health service and so forth. But I would say that for moderate, severe, and dysthyroid is even in those kind of conditions, is better that there are combined consultations of endocrinologists and ophthalmologists.
Thank you. And one question for you, Dr. Salvi. What is your opinion about doing thyroidectomy in patients who are resistant to medical treatment in hyperthyroidism? Do you think it influences the course of the thyroid eye disease?
Well, I mean, eventually, this is thyroid ablation to some extent is the long-term event for patients with Graves' hyperthyroidism, because long-lasting remission from various series studies done is no more than obtaining no more than 35% of patients. Thyroidectomy has not been shown to have either an effect in deteriorating or improving disease. We consider thyroidectomy with a neutral effect on thyroid eye disease, and I think it can be performed if they're skillful surgeon. Usually, we do reserve thyroidectomy to patients with very large goiters or not control or disease that cannot be easily controlled by drugs.
Thank you. Piruz, do you wish to add anything?
I was wondering. I wanted to ask Mario, as endocrinologist, also a question regarding that. Indeed, the thyroidectomy has not maybe great influence on the thyroid eye disease, but radioactive iodine does. Is that clear why the radioactive iodine has such an effect on thyroid eye disease?
Well, this has been studied to some extent, and certainly the thyroid cell lysis caused by acutely by radioiodine frees some antigens that are in the circulation, and this may elicit autoantibody response. In fact, it has been shown that the titer of TSH receptor antibody after radioactive iodine has a 5 to 6-fold surge right after radioiodine, which then tend to normalize possibly in 5 to 10 years after the treatment. Whereas this has not been shown when we treat patients with antithyroid drug or with thyroidectomy, in which you have a progressive decline of the TSH receptor antibody, which usually lasts less than 2-3 years. So this has been shown, although the precise effect of the worsening of the disease has not been well elucidated. One thing that I need to say, though, is that this worsening can be prevented by applying a prophylactic course of steroids when you apply for radioiodine. And this we do on a regular basis with absolutely no change in the occurrence of the disease after radioiodine.
You do it only in active patients or in every patient?
No, we calculate, we see, we assess in each patient the risk factors, which is the titer of TSH antibody, the smoking, the duration of disease, whether, so in some cases, we try not to do it when the disease is active, although in some cases we did it while they're doing, for example, intravenous steroid treatment.
Thank you. And I think we'll move on a little bit to medical treatment. I'll shortly review medical treatment in thyroid eye disease. Obviously, as Mario said, we have to balance the thyroid status. Patient must quit smoking. It makes the disease worse and it makes them less reactive to any kind of treatment. Steroid Periogogo is still a drug of choice for very active thyroid eye disease. And in the recent era, we have the new immune modulators, the mycophenolate mofetil, anti-CD20, anti-IL-6, and IGF-1 receptor antibodies. Also, there are places that treat external beam radiotherapy for TED patient and local treatment like Botox, triamcinolone acetonide, and hyaluronic acid for eyelid retraction. These are local therapies. Surgical treatment we reserve for inactive patients unless they have sight-threatening disease like globe subluxation, exposure keratopathy, or dysthyroid optic neuropathy, which fails to respond to steroids. Otherwise, we would operate them in the inactive phase of the disease. It would be followed by orbital decompression, strabismus, eyelid recession, and aesthetic rehabilitation because each step can influence the other surgery. There are clinical data regarding these new medications. The most profound one would be teprotumumab or IGF-1 receptor antibody. It has been shown to be very efficient in proptosis reduction, in improvement in clinical activity score, in diplopia reduction, and improvement patients' quality of life. This is an FDA-approved drug for thyroid eye disease. It's actually the first FDA-approved drug for this disease. Currently in our country, it's been approved to every patient. It's covered by the medical insurance of the government, so it's not out of pocket. These are the previous publication, and you can read them all, and they are very persuasive of how this medication can help patients with active thyroid eye disease. However, there's certain percentage of recurrence after treatment cessation, and we can either give them additional drugs, do surgery, or give them another course of teprotumumab. The most common adverse effect would be muscle spasm, hyperglycemia for glucose intolerance. So we should carefully monitor the glucose in these patients, but it's not contraindicated patients with diabetes. And hearing impairment, that's why we have to send every patient before treatment and during treatment to hearing examinations. In our country, we have treated in the last 3 years 32 patients with TEPRO prior to being approved by the government. And we get significant reduction in proptosis in 2.5 millimeters and significant reduction in clinical activity score and diplopia. We had about 10% recurrence. One of the patients had retreatment. Similar data are available now for tocilizumab, and I would let Dr. Salvi comment about the current status of trials and tocilizumab. Dr. Salvi?
Yes, actually, we have we and other centers in Italy have just concluded a randomized trial, multi-center trial with tocilizumab compared to intravenous steroids, and we expect to have the results in the next couple of months.
Tocilizumab has been proved to be efficient versus placebo in thyroid eye disease in primary and secondary endpoints such as proptosis reduction, clinical activity score, and exophthalmos. Additional data are about rituximab or anti-CD20. It's been shown to be efficient versus IV methylprednisolone. And there are two studies about rituximab, and Dr. Salvi, I think you have a comment on that as well.
See, the difference was the two study gave really divergent results. The study we conducted was certainly gave 100% response with very few relapses, whereas the study conducted at the Mayo Clinic did not seem to show any change compared to placebo. When we analyzed the data together in a post-hoc analysis, what we found was really the difference in the duration of the disease being about 5-6 months average duration patients treated in Italy versus 25 to 30 months of patients treated in the Mayo Clinic. So we believe that rituximab may be used in active disease when the disease is really of short duration.
We have also shown many years back that rituximab has been efficient in patients with thyroid optic neuropathy who failed to respond to IV glucocorticoids. However, most of these patients needed to do surgery later in the course of the disease. So Mario, can you briefly update on other therapeutic development on the newly drugs?
Well, there are several ongoing trials for this disease. Certainly, one group of drugs that have been used are the drugs that are interacting with the FcRn inhibition, the neonatal Fc receptor, that have shown to, in one study with batoclimab already, have shown to decrease and reducing non-specific immunoglobulins in the blood, including the TSH receptor. The efgartigimod that is being studied now is more specific than batoclimab in doing that. And I like to mention also the fact that there is an ongoing study with the K170 antibody that is blocking the TSH receptor antibodies in these patients. A preliminary study was conducted a couple of years ago, and an ongoing clinical phase 2, phase 3 studies is ongoing in Japan and is starting in a few centers in Europe as well.
Thank you, Mario. So we've had a brief look at the data. How does that work in practice? How do we make treatment decision, and are the guidelines for helpful for us? Which drug do we choose for each patient? Which targeted therapy or non-specific therapy like steroids? Do we consider different phenotypes and impact of treatment selection? And how do we balance the risk and benefits? Some patients with severe thyroid eye disease, but not sight-threatening, they choose not to be treated. Will that impact on the final outcome of the disease, do you think? And what's the place of surgery? I think, Mario, we will start with you, your opinion on these questions.
Well, very quickly, I think the targeted has already been mentioned by Perus before, mentioning that the presentation of the disease as really presents with different phenotypes. And I think at this time, having different immunosuppressants available, we really have to target the main component of the disease. So if we want to target proptosis and diplopia, we can use tepro. If we want to target inflammation, we can use steroids and we can use tocilizumab. If we want to target other function of the disease, we can move on that. One thing that I want to mention is really it is important really to decide for treatment where the disease is really in the active phase, because otherwise it would not respond. This is certainly an important point. And also that the treatment decision have to be discussed with the patient himself and with in my case, with the ophthalmologist. So it has to be a decision among the two specialists and the patient, because the perception of the disease of the patient, or the disability of the patient, is very different. So before deciding which drug to apply, I think it is important to have an overall idea of all that.
Okay, so Piruz, what are your thoughts about the tailored medications in TED?
Yes, as Mario mentioned, that is the phenotype of those patients is important. Which group of patients they should receive. And the future, I think the future of this medication, except insulin growth factor inhibitors and TSH receptor antibody inhibitors, as is mentioned, they are coming. And just imagine, like in immune therapy in cancer or in hematologists that they are treating different diseases. I think the future of thyroid eye disease might be something like that, that we have a combination, a cocktail of medication, a one or two, that we give those patients in active stage, in moderate severe cases, in early stage, that those patients, they have more benefit, and their symptoms and also the progression of the disease can be stopped. And actually, as a surgeon, I don't regret that in the future we do less decompressions. While decompressions are very helpful, good results, but still, this is much better way of treating those patients. So I think the future will be like, in many specialties of in medicine, it would be combination and targeted therapy, in my view.
Thank you. Mario, we would be interested to hear about your guidelines, how we treat mild, moderate, and severe thyroid eye disease, with or without sight-threatening events.
Well, actually, mild disease, you can just watch and see if they, studies that have been done have shown that when the patient presents with mild disease and followed up in time, and actually we've done also some multi-center study within the UGOGO centers, group of centers, we have shown that only 3% mild disease progress to moderate severe. So that is certainly a good approach. It has also been shown that, for example, a short 6-month course of selenium supplementation, especially in areas where there is selenium deficiency, may improve mild signs of disease. And this is actually the approach we use.
And regarding medical treatment for moderate to severe thyroid eye disease, what would be your preference?
Well, I'm along with what Piruz was saying. I think that the phenotype now is the approach is to look at the phenotype of disease, and based on the armamentarium we have, which is now opening up certainly to more drugs, we may elect one drug or a combination of different drugs based on what we want to target. It is certainly one thing. It is true, and I think that the paradigm is changed, is that now we can treat this disease, which was not the case up until, I would say, 10 years ago. And this, in one way, has revived the attention to this disease. And there are more and more colleagues who are aware of the disease, although I think we still have to push a lot on the awareness of this disease being diagnosed as early as possible, because, as also Piruz was saying, the earlier we treat, the better we have. You were mentioning before the chronic patients. It may well be that those patients still have chronic disease because we did not give the proper treatment with the acute phase. But if we have a treatment for the acute phase that switches off the disease, we won't have any more chronic progression. This is one possibility.
Thank you. And Piruz, we would be interesting to hear your thought about second-line treatment, about patients who respond to one treatment, they have recurrence, and what's the place of surgical role in treating thyroid eye disease patients?
Yes, as you know, even the Tepro for 30% of cases has a recurrence. And this recurrence you can see also in steroids, that there is, and in steroids also something like 30%. And group of patients are not responsive to both medication, to steroids and also to Tepro. So tezolizumab is, as you know, is used as a second line treatment for those who are not being responsive to steroids, and one can be this second line treatment for the other.
Sure.
Um, the surgery has still a place, of course, even when in those patients who has received the teprotumumab with the reduction of proptosis. There is, as you know, every orbital wall decompression has 2 millimeter of effect, while Tepro has 2 or 3 millimeter the reduction. So yes, even when there has been a proptosis reduction, there is a place still for decompression. A group of patients that they have received all those medications still need a decompression. For sure, there is a place for decompression for patients with this thyroid optic neuropathy, and that is something that, of course, is not the first line, but after steroids, still most of patients with this thyroid optic neuropathy, they would need a bony orbital decompression.
So before we conclude, Piruz or Mario, do you have anything to add?
Well, just to mention, I think it is very important to know the long-term outcome or any other drug we can use. But my always I'm always saying the same thing at the end of any discussion. We need to do more randomized clinical trial, because that is these are the studies that are giving us the answer we need.
Thank you. Piruz?
Yeah, yes, I'm looking forward looking forward in the future, that indeed we are still getting better treating these patients, and as Mario said, we can until recently we were not able to treat these patients. We are working on the symptoms, and our decompression is still removing the healthy tissue to create space for damaged and ill tissue. So I am looking forward to be able in future giving some real treatment to these patients that they have problems in daily life. That is actually the only thing that I can say. Yes.
Well, thank you everyone for a really great discussion. So I think we all agree that we need to have more multidisciplinary thyroid eye TED clinics, along with endocrinologists, immunologists, and orbital surgeon. And we do believe that immune therapy is a disease-modifying drug, and as Mario beautifully said, if we treat them early, we might prevent long-term sequela. And there is still a role of surgical intervention, and probably in the future we will do less surgery. Thank you, everyone, and bye-bye.
This program was presented by Medscape Education Global.